We were treating AML with 7 and 3 in 1977. We are doing the same in 2018. What is the best way forward to change it by 2028?
Well, I must confess that I don't have an insightful answer to you. I can say that as a fellow, I gave plenty of 7 plus 3, which is an invention of Memorias Law and Catering, where I served as a fellow 30 years ago. I find it incredibly humbling that in 30 years we're still using the same toxic regimen. It's very harsh to give. And it's, I think, a testimony to the resiliency of the disease, which has been very challenging to articulate. I think that, just to get a little more technical, having taken my boards a couple of years ago, this trend seems to be that for elderly patients, people are not using such an aggressive regimen anymore because quality of life issues come to play a role, and many of these patients essentially cannot tolerate such a harsh regimen. So I think a conversation with patients as to what is important to them, and if you want to have a significant increase in your lifespan, but not a meaningful one, significant being statistically significant, I think this is a conversation that needs to be had. I hope that with new drug developments, and those things come in waves, so you have the angiogenesis wave, now you have the immunology wave, tumor microenvironment. At some point, we may stumble into something, and I have no idea what that would be. I am fairly sure that's not going to be non-specific cytotoxics, which is what we keep doing, which is the definition of insanity, right?
But you know, I'm really asking you not just AML, but most cancers, most common cancers, we don't have an answer that is very different than what we had.
I think it's very true.
40 years ago. And what you're saying is we'll be stumbling onto an answer at some point.
Well, as I was talking to you off camera, there is a story that is apocryphal, but the wife goes to a major cancer center in the U.S. and says, you know, you treated my husband with 5-FU. Now, 40 years later, my son has colorectal cancer. And you have all these wonderful advances that I see all the time in the news, and you want to give my son 5-FU. So how does that compute? And again, it's extremely humbling.
Yes, thank you for that apocryphal story, but it really does underscore the problem that we are all facing.
I should mention, for the interest of full disclosure, that my father died of colorectal cancer. And so I'm always concerned that those things are lurking in the background because I don't want to be a 5-FU recipient.
Thank you. Wadih, there are 3.5 million papers that have been published in cancer field. 135,000 in just last year alone. There's a staggering disconnect between great scientific insights and translation to improved therapies, as you just pointed out through the story you told us. What are we doing wrong?
Well, I think there is a great gap between transforming data into knowledge, and then an even greater gap between going from knowledge into wisdom. And I think that the science advances in a much faster pace than medicine. Medicine is a 2,000-year specialty, and we are used to doing things on a certain way. That's why physicians are trained since Greece, since Egypt. Science, on the other hand, is a fairly modern profession. And I've read as a statistic that 95% of the scientists that ever lived are alive today, which is staggering. The number of journals continue to be the same, so it's more and more difficult to publish. And despite that, you have this incredible amount of literature. And how do you convert this in benefit to mankind is still a black box. So I'm not sure that I have a lot of philosophical insight on how to close the gap, but I think as a species we should address that.
Yes, thank you. Now, the fact that children respond to the same treatment better than adults, it seems to suggest that the biology of the disease is different, but perhaps the biology of the host is very different. Since most cancer incidence increases with age, even having good therapy may not matter because of the host. Solution?
Well, protoplasma, or what physicians tend to call as performance status, is very, very important. I don't have children by choice, but I can tell you from looking at my friends' kids and my nieces, they're unbreakable. And I think the same applies for cancer chemotherapy. I think evolution designed people not to live past 40 years old. I think your immune system gets to be more problematic than effective because you're designed not to live beyond that lifespan. And I think evolution will take more than 10,000 years to accomplish that. So I think that the problem is that we are living beyond our reasonable biological lifespan. And children, I think, which is the preservation of the species again, have a built-in mechanism to be more resilient. But that's just a guess, of course.
So that, having said that, then what is the solution to finding an answer for cancer? Because if the whole protoplasm is bad and we are just doing something abnormal, then...
Well, unless we're Ponce de Leon and we find the fountain of youth, short of that, I think that studying geriatrics and trying to do the right things, live a healthy lifestyle and exercise, eat right, don't drink too much, everything in moderation, all those boring things that people tell you to do may help. But then again, you and I had patients that did all the right things and they still get stricken by these horrific diseases, usually the nice people. And they say, but what did I do? I did all the things right and I still got this. So I think Bert Vogelstein called this bad luck, which I find it interesting because it sounds very fatalistic. But I wouldn't know what's the proper solution for it, unfortunately. Those are tough questions.
You didn't expect easy ones from me.
No.
You have great knowledge and experience in the field. If you were given limitless resources to find a cure for cancer, what would you do?
Certainly not a moonshot. And I'm sorry, Patrick, I know that you were committed to that. I think that I would probably explore serendipity, which is very hard to do. I think when people start to look at the history of science, the great breakthroughs came from left field. They didn't come from well-structured, massive bureaucracies that tell you what you should do and what you shouldn't do. Next thing you know, some folks are studying worms, and all of next year they're getting the Nobel Prize for small RNAs. And this motif, I think, gets repeated over and over. You see with H. pylori and gastric cancer. I think, I'm blanking on the name of the NCI director, but he had this quote that if the NIH was in charge of curing polio, we would have the best iron lung that money can buy. And I think that's probably true. instead of having Salk and Sabin come up with a vaccine. So I think individual talent and creativity is key. And I'm just fearful that mega projects divert the number of resources that by definition are limited. So I think the question is a hypothetical. What if the resources were not limited, but they are limited? So I think that the right answer would be to give to individual scientists. Don't tell them what to do. And then you harvest the best ideas and results rather than to try to people on a moonshot, which I think is a very nice concept if you are doing engineering, because the outcomes are known, and in medicine and biology is a much less exact science, so it's not a problem of just pouring resources, it's creativity.
I have to tell you, you've given the most interesting answers
Oh.
so far of a lot of people I've interviewed already, because you have a very unique take on all of this, a very practical and unique take.
Well, I really, it means a lot to me to hear this from someone like you.
Thank you. Now the last question is a deeply philosophical one, which you and I address almost on a daily basis. Offering patients with advanced stage, non-curable cancer palliative but yet toxic treatments is a service or disservice in the current therapeutic landscape?
I think it's both. I think that, again, I mentioned a little vignette about my father. He was like clockwork. He had metastatic colon cancer, and within 3 years, he went through the various chemotherapies and died on schedule. What is not immediately obvious is that behind my father going to the doctor and getting these toxins and so on, and be very happy because his CEA was low, there was a lot of side effects and complications and trips to the hospital and infections and so on. And my mom going behind him, and she suffered not nearly as much as he did, but psychologically and so on. So when Renata's father passed from a fulminating heart attack, I called my mom and I said, Renata's father passed away. And she said, oh, best thing that ever happened to him. Because, you don't want to really go through years of sheer misery. Now, different good people disagree about what to do about those situations. And I think the level of comfort is a negotiation between you and your patient. I think physicians, by definition almost, they will have their gray zones and their line of comfort. And you and I probably can guess on a certain situation which a colleague would do based on past experience. And you may or may not agree with what they do. That I'm talking now not as a family member or a patient myself, but as a professional. Now, I think it's well worth a conversation because in America they have this concept called paternalism, which is a no-no in American medicine. You're not supposed to tell patients what they should do. You're supposed to give them options, and they should decide. Is the patient autonomy is the principle. I come from Brazil, and I come from an Italian background and a Middle Eastern background. I'm Greek Orthodox. None of those things sounds real to me. Most of my patients were take care of me doctor, and they would interpret something like this as a neglect of my professional duty of telling them what to do, which of course puts the burden of responsibility on you. So I think over the years, and again, I'm just turned 59, and I've spent 30 years in the U.S., so I think I'm more American than Brazilian now. So I developed this hybrid model in which I try to feel the patient and see really what they wanted to do. I also tend to say, look, I'm very happy to give you your options, and then if you want me to, I can tell you what I would do if I were you, which I think combines the best elements of both philosophies. I went a long roundabout way. I'm not sure if I responded to your question, which is a difficult question to answer. But I think that basically you need to be honest with your patient, but also honest with yourself. And always keep in mind that palliation means symptom control. And if you blast someone with cytotoxics to gain a small, again, significant, but clinically meaningless increase in lifespan at the cost of a great toxicity, you need to really step back and think if you're doing your patient a favor. So, and we go through this on a daily basis. That's why it's called practice.
That's a very beautiful meditation on end of life care. Thank you very much.
No,
I really
thank you.
appreciate your cooperation. Have a good
I look forward to seeing the project.